Today we're going to also talk about how to read chest X-ray. So this is just a summary. So I'm sure by now you have an idea. You should have when you watch this video, you should have an idea on how to read chest X-ray. So this is a summary. Okay. So of course the first thing is when you ask to read a chest X-ray or any X-ray, so you have to begin with the demographics or details. So I have to check the patient's name and the date the image was taken. Then two, you have to mention the type of film and position. So check the type of film and the position and direction. And also if we so the or some of the types we have posterior anterior, that's PA, then AP, that's anterior posterior, then we have lateral, then we have lateral decubitus. Then you also have to take note if the patient is upright or lying down. Okay. Then upright patient you usually see fluid levels in the stomach. That's for upright patients. So there are fluid levels in the stomach when the patient is upright. You see a fluid level in the stomach, and when they are lying down, you can't see that. So it's usually in the bowels. That's when you actually appreciate the fluid levels. Okay. Then for PA versus AP view, so for you to differentiate between PA and AP view, so clavicles in posterior anterior view, they are actually over lying fields, but in anterior posterior views they are above lying apex. Then the scapula in posterior anterior is away from the lying fields, it's away from the lying fields. Then the anterior posterior is over lying fields. Then in the ribs are posterior ribs are distinct. So that's for PA. Posterior ribs are very distinct. And then for anterior posterior, the anterior ribs are distinct. Then the heart in PA is should I don't want to say normal, but it's not relatively enlarged. So that's the other thing you use to notice for an AP view. Okay. Then technical quality. So this is the technical quality. So we use the mnemonic RIP. So R for rotation. So is there equal distance between the middle end of the clavicle and midline? Or spinous process halfway between the clavicle heads, therefore normally rotated. So this just means if you see the X-ray, then the rotation you have to check the clavicle and the midline. If the spinous processes are halfway between the clavicle heads, then the rotation is normal. Then inspiration, adequate inspiration. So if the inspirations were adequate, you are actually going to see 5 to 7 anterior ribs which are intersecting the diaphragm. Then more ribs means the lungs are hyperinfiltrated, often seen in COPD. Also, then the other thing is there should be 1 to 10 posterior visible ribs in adequate inspiration. But remember, anterior ribs 5 to 7 for inspiration, for adequate inspiration. Then P for penetration or exposure. So it may be over or under. So it can be over penetration or under penetration, or over exposure or under exposure, or too bright or too dark, or that's what it means. So if it's normal, we say adequate exposure. So when it's too bright, you know that it was over penetrated. When it's too dark, it was under penetrated. Okay. Then four, look at the bigger picture. So can you immediately see any larger lung mass or obvious abnormalities? In just the bigger picture, the thing we can just see immediately. Okay. If there isn't any, then you comment. You don't have to comment on it, but if it's there, you comment on it before you go to the ABCDEFGHI approach. Then A is for airway. So is the airway normal? So if it's normal, you have to look at the trachea if it's centrally located and open. Then if it's if it's not normal, then it can either deviate away or toward the pathology. Okay, then B is bones and tissues. So start from the top. You have to count the bones. Then you have to check for fractures, rib fractures in this case, and clavicle fractures. Then lesions, for example, in multiple myeloma, so you have to look out for any lesions. Then you have to check external soft tissues for any abnormalities, for example, in subcutaneous emphysema. Then that's for the B. Then C is cardiac silhouette or shadow. So in posterior anterior, the thoracic ratio is less than 50%, which is less than half. Then the normal cardiothoracic ratio should be visible, and cardiophrenic angle should be visible and sharp. Then if there is an enlarged cardiac silhouette, we say it's cardiomegaly. Then the other thing you can use to check for cardiomegaly, you can just clinically, without, you can calculate it. You get the entire cardiothoracic, the cardiac shadow divided by 1. But clinically, the thing you can do is you can just use your arms. You can just use your fingers and just use your fingers to measure the length of the cardiac shadow. Then you have to put it across the lips, from where the first lips, there is the parenchyma markings. So this is hard to explain without me showing you, but the thing is, you can just use your fingers, start where you are seeing the cardiac shadow. The edges, so follow the edges where they are, then you put your fingers across them, then put them on the first where the spines show. So if you see that one of your fingers is moving out of the chest, then that means it's cardiomegaly. Yeah, but this is easier if I'm actually showing the exact x-ray. Okay, so which I'm going to do, because there is one here. Okay, then there are also other abnormalities such as pericardial effusion, water sign, right ventricular or enlargement, then left ventricular enlargement, CCF, pulmonary hypertension, microstenosis, or have other abnormalities. So it's not just about you knowing how to read the chest x-ray, it's also about you knowing conditions and what they actually represent on the chest x-ray. Okay, then D is for diaphragm. So is the diaphragm normal? So how does it look like if it's normal? It has sharply visible border that curves down the edges of the costophrenic angle. Then if they should be visible and dome-shaped angle with angles intact. Then abnormalities we can have obliteration of the costophrenic angle, especially in pleural fluids, pleural effusions. That's when it gets obliterated, but of course there are also others. Okay, then E is for the edge of the heart. So of course you have to check for the end silhouette sign. So if there is a consolidation, either right or left middle lower lobe consolidation, find that the cardiac shadow and the consolidation will make a silhouette sign. That's what it means. So also, of course, you have to look for any other abnormalities on the edges of the heart. Okay, and of course, you have to check if they are clear or also not defined. Okay, then we are now on F for fields of the lungs. So normal lung fields are roughly symmetrical with lung markings, lung tissue parenchyma. Then when describing lung fields, there are no correct terminologies. So can you see where the lung markings are absent or deviated from the parenchyma? Then is there any abnormal shadowing, opacities, or fluid levels? The normal lung markings, you have to know what they mean. Okay, that's for F. Then we're now on G for the gastric bubble. So normal bubble is a small dark area under the diaphragm with the fluid level. So this is uh, this is to your left, because that's where the gastric bubble is. That's the normal bubble. On your left there should be a gastric bubble, but on the right, if there is air under the diaphragm, that's another issue. Okay. Then if there is hiatus saying it will be above diaphragm, so that's one of the conditions where you have the gastric bubble above the diaphragm. And then higher, uh, normally only pulmonary blood vessels are visible. Then visible lymph nodes and abnormal findings, e.g. higher lymphadenopathy, of course. You should know which conditions you can actually see these. Then you have to look out for masses or calcified areas. Okay. Then we are now on I for instruments. So things doctors put into or on patients, such as tubes, pacemakers, wires, or sometimes you can even know what it is, because maybe it is coming out of the patient, so you are just able to see it. Okay. Then summary. So it's a good idea to go back and summarize your findings. So this is what I was talking about. So if you put your finger here and here, so with that in mind, with these edges, with these two edges, then you have to put your fingers, don't move them, so just put them here. This is the end of the angle, so that's where you are supposed to put your finger, which was here. So here and here, that's where the fingers were. Then you move them to this side, so don't change. That's the length of the cardiothoracic ratio. So after you put them this side, then you have to put the other one. If it was at this side, probably at this side, that's the half. So if it's not going towards this, it means that it's not enlarged. But if you have a cardiac shadow where your first finger is here, sorry, your first finger is here, then the other one is this side. Then if you put your finger this side, you find that the other one is going to reach this side, as it's crossing the other lung sides. That then you know, okay, that's big. But otherwise, clinically, you can even just tell, okay, this is cardiomegaly. Otherwise, but okay, this is the X-ray we have here. Okay. So I want you to pause and try to read the things you can see. Okay. So this is an upright posterior anterior chest film of Mr. Emerson, taken on the 1st of January this year. Then exposure is adequate, as you can see. It is not too bright, it's not too dark, so the exposure is adequate. And then the patient is not rotated, and there is no motion blurry. So here we are. That's what we mean. Okay. And airway is central and patent. So the trachea, this is the trachea, it's centrally located, not deviating toward, there's no deviating away or toward the pathology. Then there are no fractures, of course, lesions, defects visible on the bones. The cardiac silhouette or shadow is not enlarged. So like I said, this one is just normal. The cardiac silhouette here is not enlarged. There is no silhouette sign. Okay. Then both diaphragms appear normal with no blunting of the costophrenic angles. So as you can see, they are sharp and there is no obliteration of the costophrenic angle here. Okay. Then the edges of the heart and major vessels are clearly visible. So this is what we mean. These are the edges and major vessel here. Then these are clearly visible. Okay. Then where were we? Okay, visible. Then the left and right lung fields are clear throughout. So this is clear throughout. There is no deviation from the lying parenchyma. As you can see, they are just clear and visible. Okay. Okay, then the gastric bubble is visible and there is normal aira shadowing. Okay, so gastric bubble on the left side, which is here. So this is the gastric bubble you are able to see here. That's the gastric bubble. Okay, and sometimes you may see it even big like this from this side. Okay, that's the gastric bubble. On the left side, that's the normal one. But if you see air under the diaphragm this side, on the right side, you know that that's another pathology. Okay, and then that's all. Then in conclusion, in summary, this is a normal upright chest fume, because that was normal. There was no pathologies, but this is just a summary, so you have to actually know the pathologies before you read that a chest x-ray. But these are the principles of reading a chest x-ray. Have a good fortune ahead, and thanks for watching.